So NET cancer, we think, originates in endocrine type cells, which are scattered throughout our body. We divide NET cancer into two big categories. One of those categories are NETs that start in the pancreas, and those are called pancreatic neuroendocrine tumors. And the other category are neuroendocrine tumors that start outside the pancreas. We call those carcinoid, and they can arise almost anywhere in the body, but usually start either in the lungs or elsewhere in the gastrointestinal tract. This is one of the big challenges in NETs because you can't really pinpoint an exact symptom for NET. One of the reasons is that they can start in so many different parts of the body, so the symptoms that they will present with are going to be dependent on where they start. So someone who has a NET in the lung might have a cough or asthma type symptoms. Someone who has a NET in the small intestine might have symptoms of abdominal pain and cramping. The other aspect of NET is that in addition to having these different anatomic locations, they can secrete hormones, and they can secrete different types of hormones. Those hormones cause symptoms. For some people with carcinoid, the hormones will cause flushing and diarrhea. That's called carcinoid syndrome. And for people who have NETs in the pancreas, they can have symptoms from hormones like insulin or glucagon.
Well, many patients have symptoms that may be related to where the tumor is or the bulk of the tumor. So those symptoms might be pain or discomfort. Some patients have symptoms that might be related to the hormones that are being produced by their cancer. And those symptoms might include what we classically consider to be a carcinoid syndrome. For patients with small intestinal neuroendocrine cancers, sometimes hormones lead to flushing and diarrhea. And I think making that connection between those symptoms and entertaining the diagnosis can hopefully lead to an earlier diagnosis of neuroendocrine tumor. Right. I think that certainly if this is something a patient is wondering, it should be brought up with a doctor. You know, if that diagnosis again is entertained, that can lead to more standard testing, whether that be blood work or urine testing or imaging as indicated. So I think, you know, whether we hope that raising awareness within the medical profession will lead doctors themselves to think of the diagnosis, but I would encourage patients, if they're concerned about it, to bring it up with their doctors.
This is another challenge in another area that we've been very interested in, trying to identify tests that will diagnose NETs early, because it's absolutely key to improving prognosis and improving treatment. There are other types of cancers where there have been established tests, and one example might be PSA for detecting prostate cancer early. We just don't have an equivalent of PSA for neuroendocrine tumors. So right now, I think the best recommendation is just to try to increase awareness of NETs so that physicians will at least think of the diagnosis if they have a patient that has some unusual, unexplainable symptoms. And if they think of the diagnosis, then at least they can do some of the more standard tests, whether it's CAT scan or endoscopy, to try to identify these NETs early. So one of the reasons it's hard to detect is that there is no one specific symptom that you can pinpoint. Another piece of the story is that NETs sometimes do grow more slowly than other types of tumors, so they can cause vague symptoms, sometimes for many years, before they're actually diagnosed.
Right, so neuroendocrine tumors are a very diverse group of tumors. Patients present at different stages of disease, from localized, hopefully curable disease, and some patients with advanced disease. It's really important for patients to know that there are different varieties of therapy, and this is where it's so important to have a multidisciplinary approach to treatment. For some patients, surgery will be important. For some patients, nuclear medicine therapies or interventional radiology therapies will be very important. And for other patients, medical therapies will be important. But for each person, treatment is very much individualized, and it's important to come up with a team of doctors who are experienced with neuroendocrine tumors to come up with the best treatment for each person. I think the biggest obstacle is devising the best treatment plan for a patient, realizing that it may take a multidisciplinary approach. The biggest obstacle in terms of managing patients, I think right now, is trying to advance and improve the therapies that we do have. And that's why the research that is going on at multiple places is so important.
So one of the keys to a good prognosis, if you will, is diagnosing it early. And that the best time, if you're going to get it, and if you're going to diagnose it, is to diagnose it at a time that it hasn't already spread to other organs. In those types of situations, a surgeon very often can go in, take it out, you'll be cured. You never have to worry about the neuroendocrine tumor again. As we were just talking about, though, one of the challenges is diagnosing these early because the symptoms are vague, they can be there for years and years. So many of our patients are diagnosed at a later stage when it's already spread and it can't be cut out. The good news there, though, is that this can be a disease that people can live with. They can live with very well with minimal symptoms if they get appropriate treatment for years and years and years. Well, the reason, at least historically, that might have been the case is that the symptoms are vague. They can mimic other types of far more common conditions. One of the things that we do sometimes see is people who have been given a diagnosis, say, of irritable bowel syndrome, which is very common, and in fact years later are diagnosed, say, with a carcinoid tumor that might have been the cause of those symptoms. I will say that there is good news. I think more recently, we recently did a study that suggested that at least the majority of patients now are getting an accurate diagnosis and are getting it in a timely fashion. So I do think there's been some progress. So 2010 is an interesting year. It was the year right before the new targeted therapies became available. So in 2010, we were still, at least in part, thinking about whether or not some of the traditional chemotherapies are going to work, are going to be effective. 2011 was the year that targeted therapies became available, and our thinking now really revolves around that. What are some of the pathways we can target? How can we best target the pathways to slow the growth and hopefully ultimately shrink the tumors and ideally cure them?
So after Jane's death in 2010, there have been 2 new therapies approved by the FDA for treatment of patients with pancreatic neuroendocrine tumors, sunitinib and everolimus. These medications represent a class of targeted therapies, and I think that's where we've made the most progress in treating neuroendocrine tumors, is establishing the role of targeted therapies. We're trying to better understand what predicts response to these therapies and how to incorporate these therapies into the treatment of patients with neuroendocrine cancers.
So if somebody came through the door today at the same stage that Jane was at, with the same symptoms and so on, would her prognosis be any significantly different than it was in September of 2010?
Well, we hope that with the introduction of medicines like sunitinib and everolimus, that slowing down the progression of cancer will lead to improvement in symptoms. So I think overall we expect that with these newer medications, patients' prognosis is going to be better.
Another one of the big mysteries for NET cancer. One of the clues is that, at least in rare cases, neuroendocrine tumors do develop within families. They're inherited genetic syndromes. Those are very, very rare. They probably account for less than 5% of all the neuroendocrine tumors we see. We don't know the cause of the other 95%. There may be some genetic underpinnings that we haven't discovered. That's one of our big efforts right now in research, is to identify that. So one of the obstacles, and I think this has been more of an obstacle in the past, is that it's been perceived at least as a fairly rare disease. So if you wanted to go figure out what happens to patients, or if you wanted to get some tissue samples to study, you'd have a very hard time identifying those because there were so few patients where that was available. One of the strengths of having a program like we do is that we do see patients from all over the country, from all over the world. we're able to collect their information, collect the samples, and we have those now to be able to really study them. So that's not as big as an obstacle as it was before. The bigger obstacle, I think, right now is finding out what are the biologic underpinnings of neuroendocrine tumors. What is making these things grow? We don't have a great idea yet. That's one of our goals.
I think the biggest obstacle for researchers is to better understand the biology of these cancers. And we hope that by understanding the biology better, we'll be able to understand what drives the growth and target those pathways that may be active in supporting the growth and spread of disease.
Just in the past few years, there's been a very dramatic shift in how we think about treatments for neuroendocrine tumors. At least a few years ago, we were trying traditional chemotherapies and, with a few exceptions, not having a whole lot of success. In 2011, 2 new biologically targeted drugs were approved for neuroendocrine tumors. One of those is called Afinitor, the other is called Sutent. And that really opened up a whole new range of drugs that we can look at and that we are looking at to improve treatments for our patients. I think one of the most exciting things is that I have the sense that we have a huge opportunity here. I'm not sure we've really pinpointed it. The drugs that we know work, that can at least help slow the growth, are targeting specific pathways that are driving neuroendocrine tumor growth. It seems to me that there's got to be a key. These are unique tumors. They all look pretty similar. There's got to be a key that we can identify that we can really hone in on to get much better treatments for our patients.